All right, in this video we're going to be talking about stabilization. We talked about stabilization for the scapula, we've talked about stabilization for the hip. We're going to be talking about stabilization for the trunk as well as for the cervical spine in this video. And so the first thing we really need to think about is what muscles are we after? What are we specifically trying to strengthen to try and help keep those spinal joints more appropriately aligned with each other and able to kind of hold their positions. Table 14.1 in your Therex book has a nice description of the concept of the global trunk muscles versus the deep segmental trunk muscles. So when we think about the global ones, those are things that extend through multiple levels of the vertebral column, either at the cervical spine or through the thoracic and lumbar spine. And if we look at cervical, we're talking about things like sternocleidomastoid that attach to your head and then also attach to your clavicles. They don't really touch on the vertebrae at all, but they definitely help us move our neck. Same thing with the rector spinae on the back, upper traps, levator scapula, the scalenes on the side. None of those really attach and are able to act individually at one given vertebral segment, say between C3 and C4, between C4 and C5. They're basically, when we contract and tighten them, they're going to kind of pull the head down and compress multiple segments together, and that does make our neck more stable, but it's not really what we're after with segmental stabilization. So those muscles that I just mentioned are all pretty much our global trunk muscles or global cervical spine muscles. When we look at the neck, we're talking mostly about trying to activate things like the longus colli muscles and multifidus. In the lumbar spine, we're looking at transverse abdominis as being one of those primary ones. So we're not really after muscles that we can palpate very effectively. And so we have to teach patients how to recognize the position of their neck, the position of their lumbar spine, so they can become aware of what position they need to be in that we want them to strengthen them around. So you can put somebody in a bad position and you could increase their strength and make that segment, whether it's lumbar spine or cervical spine, more stable. But if it's not in a good aligned position, it might not be great for their joints, it might not be great for their discs. So a lot of what this comes back to is making patients aware of what their neutral position is for both the cervical spine and for the lumbar spine. And so if we think about forward head position, which we've talked about in different classes a little bit, if I show you the view from the side, I have somewhat of a forward head. I've worked on it some over the years. It used to be worse. But essentially a forward head, you're going to be in lower cervical flexion, but in order to keep my eyes level, I've got to kind of crank my head up. So if I just flex down and then lift my head up, I'm in a forward head position. So I've got extension going on up here, but I've got some flexion going on down more at that C5, C6, C7 type level. So we want that patient to not be in this position when we strengthen them. We want to get them back into a better postural position, more neutral alignment, and then try and engage those muscles in a way that we can get them strong. Same thing with the lumbar spine. I'm going to tuck my shirt in a little bit so you can kind of see my low back, and drop this height on my tripod down just a hair. And so if we look at our lumbar spine, again, we can have somebody in more of lumbar flexion, where you're going to have a flat back, more kyphotic almost, or we can have them where they're more in that anterior pelvic tilt, where they've got a whole bunch of lordosis. And so we want them to help them understand what's neutral for them. It's essentially halfway between their most extended or lordotic position and their most kind of flat back position. And so we need to kind of teach them what that feel is. Where is that midpoint? Find that middle ground, and that's kind of where we want them to be when we try and teach them how to strengthen those muscles. So if we put them in the proper position and then really try and teach them how to engage, activate those muscles, and build strength in that position, then they're more likely to be able to maintain that position when they start engaging in functional activities, going about their daily life, whether it's sitting activities, standing activities, lifting activities, anything that might put them at risk. And bad sitting posture is a big problem both in the lumbar spine and the cervical spine, and our society spends a ton of time in sitting, so it's definitely an area that you need to understand. The Therix book does a great job, goes through chapter 14, chapter 15, chapter 16, I think it is, all kind of address different spinal issues. So I would highly recommend reading through that. One of the ways that we can help teach patients, I'm going to raise this up a touch, teach patients what we're after and what muscles we want them to use and kind of how to recognize when they're using them, is our stabilizer cuff. And so this was designed, I think originally somebody just used a blood pressure cuff to kind of figure out how to work this and use this as a teaching tool. And so then they came out with this device and marketed it. And so now they sell these. So it is essentially just like a blood pressure cuff would have. You've got your little bulb that you're going to pump up, you've got your dial that you're going to read, you've got your tube connected, and then you've got your bladder. And so this bladder's got a couple of snaps on either end. It'll only fold out like this, so it doesn't fit around your arm, even if you have a thin arm. It doesn't have any Velcro or anything like that. We can use it in this open position when we're teaching people how to do lumbar exercises, lumbar stabilization exercises. If we're working on cervical, then we're going to keep it in this more folded up position. And we've got certain pressure values that we're going to have as targets for the patient to work in. And so it's essentially a form of biofeedback. They're going to be able to visualize the dial while they're trying to engage muscles and put some pressure on this or take pressure off of it so that they can recognize the appropriate way to activate those muscles and know when they are activating them correctly, as well as knowing how firmly they need to push or how much pressure they need to take off of this cuff when they do it. So most of the time when you're going to use this, you're going to have the patient in supine. You can have them in prone to teach lumbar if we're trying to help them understand how to activate transverse abdominis. But most of us don't do a whole lot of things in supine other than sleeping. So it's easier for a patient to isolate some of these motions when they're in supine because they can relax the rest of the body. They're not having to support the body weight. But we want them to be able to transfer that sensation, that proprioceptive feedback, to a standing position or a sitting position, because that's where we do most of our activities in life, either in one of those two postures. So I'm going to stop the tape. I'm going to stop the tape because I've got to adjust my tripod so I'll have a little better angle for this, and then we'll kind of go over how we're going to deal with that for the C-spine. All right, I may have given you a few extra seconds of me moving around the device. I thought I'd put it on pause, but apparently not. So I'm in supine, actually in hook line with my feet up, and this is a good position to teach these exercises in. What we're after with cervical spine is essentially a chin tuck, and so it's just a gentle head nodding type of motion. So you want to think of kind of the occiput as being your pivot point, more or less, And so if I'm in this position here, I'm kind of in this forward head position. My eyes are looking more this way instead of looking straight up at the ceiling. And so we want to get them in that position where where their eyes are looking more like straight up at the ceiling. And so we want to teach them how to do that chin tuck and bring it down. We don't want this. We don't want them to lift their head. So we're just trying to do a gentle kind of nodding motion where they get a nice double chin. It's very flattering, as is this camera angle, I'm sure. So that's kind of what we're after. And when we use the pressure cuff, the stabilizer cuff, to teach them that, I've got it folded up in this kind of triple folded position. You're going to put it in that lordosis area in kind of that middle cervical spine section. You're going to have the patient be looking at their dial. They're going to pump it up to about 20 is where we want them to start. And that's too high. This one tends to leak just a little bit. I'm going to let a little bit of air out. And if you've got it too high, it's going to jack your pressure up really quickly. I'm going to start out with nothing on it, I guess. Or very little on it. All right. So I've got it kind of low. I'm going to pump it up to about 20, which is close to there. That's actually a touch more. It's about 22 or 30. Let me back it off. I need to look at it. I was trying to do it where you guys could see it. All right. So I'm at 20. And we want to teach the patient to do just a gentle chin tuck until that pressure just bumps up about 2 millimeters of mercury. And then we want them to hold that position. So we're going to have them do multiple repetitions of trying to hold it for 10 seconds and just trying to exert 2 millimeters more of pressure at each stage. If they get where they can hold that pressure for 10 seconds and they're up to 30, that's our stopping point. And from there, we really just work on endurance. So we work on one set of 10 second or one repetition of 10 second hold at 30, 2 repetitions of a 10 second hold at 30, 3 repetitions of a 10 second hold at 30. That would be kind of the top end, working up to 10 reps of 10 seconds each. So essentially 100 total seconds. So we're trying to work on endurance for these muscles. These are postural muscles. They're type 1 muscle fibers. So in order to train them effectively, we need to make the training match their abilities. So if they can't hold that pressure and they start slipping back out of position, then we don't want them to move higher up. So if let's say I do it and I get to 24 millimeters mercury, then I'm able to hold that for 5 or 6 seconds, and then I fatigue and my chin lifts and I decrease the pressure, then I don't want to go up to 26. Assuming they can do 22 and they can do 10 reps of 10 seconds at 22, then they'd be appropriate to move up to the next level. And when you look at the gauge, you'll see different colors. And so if you look at the one that's at 20, you've got at every 2 millimeters, you've got a different color. And so that helps the patient recognize if they're pushing hard enough, if they're not pushing hard enough, and lets them kind of work their way into it. And if they start slacking and losing that muscle endurance and falling off a little bit, then that pressure is going to lessen. So if I am in my position here and I do my chin tucks, you can see that pressure probably climbing when I tuck down and when I back off. Tuck down and back off. And again, you're going to try and see if they can push down, hold it for 10 seconds at whatever pressure level they're at, and then they're going to back off. So that's kind of the basics of how we're going to do the stabilization cuff with the cervical spine motions. And then we'll kind of talk in a little bit how we're going to progress, how we're going to make it more challenging than just having them move doing that chin tuck. Ultimately, we want them to be able to use their arms to perform activities while they're also holding that proper postural position with their neck. So I'm going to stop the tape just a sec and move it down to lumbar spine, and we'll kind of talk about that one. All right, so when we're teaching lumbar spine stabilization exercises, more common positional fault that people tend to have posturally is too much lordosis. So we need to teach them how to activate transverse abdominis primarily. We don't want to use those global movers of the trunk like rectus abdominis and the obliques. We're trying to get after the deeper muscles, so multifidi and primarily multifidi and transverse abdominis. Those two muscles, they've done EMG studies. They essentially kind of work together. When we activate transverse abdominis, it tends to cause kind of a reflexive almost triggering of the multifidi at that level to activate too. So if we're getting good TA contraction, we can kind of assume that we're going to be also getting a good multifidus contraction. And multifidi are these small little muscles that go from one vertebrae to the next. And so we're really after that deep segmental stabilization is the term that you want to think about. Teaching people how to activate transverse abdominis can be a little bit tricky. Most people don't intuitively kind of know how to do it. You can talk about kind of having people suck in their gut a little bit, but you have to be careful with that because you can, especially if you close off your glottis, you can kind of use your diaphragm to create some big pressure difference changes between the thoracic cavity and the abdominal cavity and cause a lot of abdominal movement, but that's not really what we want. We want to just think about activating transverse abdominis to make the abdominal wall flatten. It does pull in, but it's not like we're just trying to suck in our gut a ton. So I'll kind of show you the difference on those two. If I just use my diaphragm, I can suck in like that and suck in a whole bunch. And that's not really engaging TA that much. What I want to do to engage TA, and you're going to need to get fairly low on the person, you need to find their ASIS. So on me, that's right there. Come kind of just inferior to it so that you're not on the obliques. When you're doing this, you'll feel it if, and I would suggest nothing practicing on yourself. If I just try and tense up my whole core, you're going to feel the obliques kind of push up into your fingers. It's compressing everything down, and your abdomen actually kind of pooches out to the side a little bit. So if I'm right here, again, on that ASIS and coming in just a little bit inferior to it, and if I tense everything up, I'm actually causing more pressure. What I want to do is just think about kind of almost like when you breathe out gently, just kind of, and you should feel a muscle tighten up in there. So TA is going to be right in there. That's the easiest place to palpate it, and that's what we want to kind of teach the patient. We can have them put their fingers there too, once we kind of understand and help them learn what they're looking for and trying to feel. So we're trying to think about following in the gut, trying to pull it in, and that's going to, when we do that, it's going to essentially cause us to push back into a little bit more of flexion in the lumbar spine. Because again, lordosis is too much extension at those lumbar vertebral segments. So that's kind of what we're after with that. And again, if you see muscles up here tightening, you're probably getting obliques and rectus, and that's not what we want. We want just trying to activate TA so that we're just tightening up that deepest muscle that runs horizontally. So it's going to cause flattening of the abdominal wall, but again, you shouldn't really see rectus popping up. You shouldn't really see the obliques popping up a whole lot when we do that. When we use our cuff, we're going to unfold it. We're going to slip it in that lumbar spine region, so it's just going right across horizontally. We're going to pump our dial up to about 40. And you want the patient in hook line with this. All right. Kind of have to let it stabilize a touch. So it's at about 40 right now. And what I want the patient to do is to understand how to activate TA and push into it. And so it should make it climb a little bit when I'm activating that. We don't want it to go up any higher than about 50, and we don't ever want to see it drop lower than about 30. So we want to kind of keep it plus or minus 10 millimeters of mercury off of that baseline of 40 that we're after. And again, the first part is just teaching them how to do that kind of pelvic tilt by engaging TA. We're going to see a little bit of a posterior pelvic tilt that's going to flatten out that lumbar spine and, again, try to have them get in that neutral position. We do need to teach them what their neutral is. And so in this position in hook line, you can essentially have the person try and go into as much lordosis as they can, and then try and have them really push down into a flat back, and go into a ton of lordosis and try and push down into really flat back. And what we want for these stabilization exercises is we want them to be in that midpoint. We don't want them to be way up here. We don't want them to be way down here. We want them to be kind of halfway in between. Let them feel where that is, and then teach them how to activate that TA. And by activating TA, we're also going to be activating multifidus. So that's kind of the goal with those. Some people prefer to teach using the stabilization cuff in prone. If we're going to do it in prone, you're going to lay on top of it. You're going to push the pressure higher because they've got a lot more body weight on it. You're going to go up to about 70 when they do that. And then again, they're still trying to activate TA, and so we should see the pressure drop. If they're activating TA appropriately and they're laying on it, if we start them at a baseline of 70, they should see that pressure drop a little bit. Somewhere between 6 and 10 millimeters of mercury is kind of what we're after. So let me see if I can pump it up and see if I can show you the dial when I do that. I don't know how this is going to work. So that red line is somewhere about 70 on me, or it was. And so if I'm activating TA, it should drop. You want them to hold that for 10 seconds and then let it relax. When I relax, I'm putting more pressure on it, so that pressure should increase. When I activate TA, I should be contracting those muscles, lifting them up off of the cuff, and that should lower that pressure. Again, about 6 to 10 millimeters of mercury. And so it can be a little bit hard for people to kind of see that when they're in prone. But it's long enough cord that they can kind of look at the dial and try and adjust those pressures that they're feeling. And again, we're trying to teach them through biofeedback proprioceptively what it should feel like to them when they decrease that pressure. When we're doing either of those cervical motions, again, with the cervical motions, you're typically trying to increase the pressure because you're kind of pushing down into it. Same thing if I'm in hook line for the lumbar spine, I should see the numbers climb when I'm activating TA. If I'm prone, I should see the numbers drop because I'm essentially lifting my belly off of it. But if I'm in hook line, I'm flattening my abdomen, but that's also going to push the low back into the pad or into the cuff to cause that pressure to increase a little bit. So that's kind of the basics of using the stabilizer cuff. If you have a blood pressure cuff at home, and I don't know how many people do, you can certainly play around with it and try it with this too. If you're doing it with cervical spine, I would just try and roll it up kind of tight and then pump it up. You could still use those same values and it should work fine. If you're working on lumbar spine, you could unroll the cuff all the way, pump it up to the appropriate levels of, again, 70 is kind of our target when we're in prone and we're trying to tighten the TA to lessen that pressure 6 to 10 millimeters. And if we're in hook line, we're starting with that baseline at 40. And when we engage TA, it's going to flatten out that low back and push into it. And we should see it go only up to about 50 at most. We don't want it going into 60 or something like that. That means they're flattening out too much and they're moving beyond that neutral position. So we want them to really focus on understanding what their neutral position is, both for the C-spine and the lumbar spine, and then activate those muscles so that we can help them know what position they need to hold when they're trying to stabilize these things. And so I'm going to stop the tape for a sec, and then we'll kind of talk about some different options and different ways that you can use this cuff, and then we'll go through a few other stabilizing exercises also. All right, so all this information is on your lab handouts that we've got for this week, which are posted on Canvas. It's also really just straight out of the book. The stuff on the lab handouts that go through all the stabilization are just, I think it's starting like around page 516, 517 in your book and going up through 525, 530, somewhere in that range. And so it breaks it down into doing exercises for both the neck and the low back in a few different positions, essentially either looking up, so either in supine or hook line, or looking down, either in prone or in quadruped, are kind of the two most common positions that you're going to work on these different things with. And so when you're in the supine position or in hook lying, then we're mostly trying to improve stabilization while we're engaging muscles that kind of flex the trunk. If we're more in prone or in quadruped, then we're trying to work on stabilizing muscles while the extensor side muscles are kind of working a little bit more. So the key thing is we want to make sure they can, for the cervical, which I'll start with first, we want to make sure they can get to do those good 10-second holds with the appropriate amount of pressure. You know, ideally we're going to go up to 30 millimeters of mercury. They can hold that 30 millimeter pressure for 10 seconds and do 10 reps of 10 seconds. Then they're kind of ready to progress to the next level. And that's where we start adding in arm motions. And when you add in the arm motions, it's critical that the patient still holds that cervical position. It's easy to do the arm motions and let your head and neck do whatever it wants, but that's not stabilizing those muscles. And so we want to teach those muscles how to hold their cervical position while we're using our arms. And so that's kind of the goal. And then we move to the lumbar spine. We'll talk about the differences there and look at some of that. So the book does a nice job, gives you some good tables and pictures and ways to progress. The basics I'm going to show you here. The progression, once somebody mastered these things in supine, then you'd move them into more challenging positions that are more upright and still trying to maintain they can hold that cervical position where they want it. So then they can move into sitting, possibly on the ball, standing, and things like that. So we'll kind of talk about initially what we're going to do with them in this kind of hook lying position. So I'm in hook lying. I'm going to do my chin tuck and try and maintain my position. When you're first teaching the patient these arm motions, you'd probably want to have that stabilizer cuff in there too, and you could be monitoring it because they're moving their arms. And you'll be able to recognize when they go out of position, because either the pressure is going to lighten up too much if I go into more cervical extension, or it's going to increase too much if I go into more cervical flexion as they do that. So the first motion is essentially we're going to try and let them do their chin tuck, and then they're just trying to bring their arms up into shoulder flexion to about 90 and back down. And these should be slow motions. If they only get to 45 and they start coming out, then have them stop there and have them work on just improving and holding that position with a lesser amount of shoulder flexion. But if they're capable of holding that neck position you want, then they can come up to about 90 and come back down. Come up to about 90 and come back down. So that's kind of the easiest one. The next one is doing the same thing, but just going into abduction. Again, up to about 90 and back down. And you want them to be able to hold that chin tuck while they're doing that. So we're coming up to there. The third one is basically just kind of hold the arms off the plinth a little bit, or whatever surface they're on, and they're going to externally rotate and come back in internal rotation. Externally rotate and come back in internal rotation. So essentially we're asking the shoulders to work through all three planes of motion that we're capable of while maintaining that proper cervical position. So those are the first kind of three basic ones. From there, we're going to get a little bit more challenging, and we're going to move into full arcs of motion. So instead of having that person stop at 90, we're going to see if they can maintain that position while they go up into as much flexion as they can at the shoulders. I'm kind of hitting my wall here. Or as much abduction as they can. Again, I'm kind of hitting the wall. If I was a little better positioned, I'd go all the way up when I do that. But again, if you see them starting to come out, stop them, correct them, cue them. A nice gentle push on their chin is a good way to remind them to do that. They can do it themselves, or we can just do it manually to try and give them that kind of tactile cue that, nope, you're coming up too much, let's go back down. And it's not about how far, how fast they can move. It's about going only as far as they can go while still holding their proper position as they do that motion. Once we get past full arcs of motion for shoulder flexion, shoulder extension, then we're going to kind of combine. So we're going to go into kind of a scaption motion with external rotation and then come back down. So we're kind of coming all the way up. And then we can actually work on kind of more diagonals. And coming back up. And again, if they're not holding their cervical position where you want, then we're going to need to stop and have them rest. Maybe go back where we were and just work on endurance and try and get more reps in the positions that they were with the arm motions where they were able to hold that cervical spine where it's supposed to be. The final progression, once we move past kind of the diagonals, is going to be adding some resistance. So you could have them working on holding that cervical position while they pull on a TheraBand or lift a dumbbell and go up into those positions. Again, it's going to create more force that they're having to generate through their scapular muscles and their arm muscles. And when they have to use those muscles more, the likelihood is that they're going to start losing the cervical position that we're after. So that's kind of the supine progression that we're after to work on strengthening those neck flexors and helping them maintain that proper position. If we look at prone, we're looking at all the extensor muscles. And so the first one we're going to do with prone, and this is kind of similar to the just having learned that chin tuck and that head nod position, is they're going to basically go prone. They're going to try and do their chin tuck and lift their head up. So they're going to be here, they're going to chin tuck, and then they're going to lift. And they're going to try and hold this position for 10 seconds without this. So again, they want to chin tuck, lift, and hold. So that's kind of the first one. Until they master that, there's no need to add the arms. So they've got to get that motion down and be able to hold that proper position while they're doing that. The next one we're going to do is we're going to do retraction of the scapula. So we're going to try and do my chin tuck, lift my head, and then keeping my arms by my side, I'm just going to try and pinch my shoulder blades and hold that for 10 seconds. And then let it relax. Do my chin tuck, lift, retract, and hold it. And then relax. Again, if they want to build up to 10 reps of 10 seconds in that kind of position, then they're kind of ready to move to the next step. So next step, we're going to move into the arms. We're going to bring the arms up into a higher position where they're having to work a little bit harder and do a little more lifting. So we're going to get the arms in kind of this 90-90 position. Do my chin tuck, retract and lift my head, and then retract my arms this way. So mostly by bringing me out into abduction, it increases the load a lot relative to having that arm by my side, where I'm not having to lift as much weight. By increasing the length of that lever arm out to the side, it's going to make it that much more challenging for the retractors to do that motion. From there, we're going to go into shoulder flexion.